Good day, ladies and gentlemen. My name is John Ince. I'm a professor of translational physiology, and I work at the Department of Intensive Care at the Laboratory of Translational Intensive Care in Erasmus Medical Center, Rotterdam, the Netherlands. And I would also like to introduce to you Matthias Hilty, with whom I did a lot of the work that I'm going to be describing in this presentation, who is an intensivist privat docent in Zurich Intensive Care Department. We both have a disclosure information which is important in that we are stockholders and run a company called Active Medical, which makes the microtools software, which I will be talking about in this presentation, available, including products and services relating to clinical microcirculation. So let's start off. It is by no means, it is very clear that the ultimate purpose of the cardiovascular system is really to provide the microcirculation with oxygen-carrying red blood cells to provide tissue cells with oxygen needed to support oxygen phosphorylation. Everybody knows this. So red blood cells must get to the microcirculation, offload their oxygen to provide the subrates for the mitochondria to make the ATP, which is needed for the sodium-potassium pump. So far, so good. And shock is certainly the state in which the circulation is unable to deliver sufficient oxygen to meet the demands of the tissues. So oxygen transport is the key component. And if we look, however, at all of the recommendations and descriptions in the many papers describing shock and resuscitation, we see that there are various surrogates for improving tissue perfusion, like blood pressure, but that the ultimate rationale for administering fluids, for example, or vasoactive compounds, is to improve tissue perfusion. You read it everywhere. And more precisely, if we look at it in this particular review paper by Professor Vincent de Backer, it is to improve microvascular blood flow. So we have here already two concepts, tissue perfusion and microvascular blood flow. So what do we need exactly? So there are various techniques which have been described in the literature over the many years, which look at the various methodologies for looking at tissue perfusion, and specifically the microcirculation. In this review paper, there are several techniques like laser Doppler, SVO2, NIRS, reflectance spectroscopy, gastric tonometry, all of which purport to measure some aspects of tissue perfusion. And of course, it's much too much to go into these techniques one by one. In any case, a very simple clinical technique in order to do this is to look at the capillary refill time. Again, a flow measurement by looking at the capillary refill time or peripheral temperature. And indeed, these assessments of peripheral perfusion are very sensitive in identifying organ failure. More sophisticated ways of looking at perfusion measurements, for example, are by these laser speckle imaging devices, which again look at the movement of red blood cells and look at their interference patterns in order to make an image of the flow in various tissues. And here you can see examples on a kidney in which is given into shock. You see changes color. In resuscitation, you see heterogeneity, and finally back to baseline. It's also used a lot in burns, for example, looking at the heterogeneity in perfusion in these. We use this particular laser speckle imaging to look during operations at the perfusion of the brain, when motor activity was induced by finger tapping, and we could clearly see changes in laser speckle imaging on the surface of the brain during these awake neurosurgical procedures. More sophisticated methodologies for looking at perfusion is by, for example, this recently introduced photoacoustic methodology, which stimulates the red blood cells, causing small changes in their acoustic properties, which then can be imaged. However, all of these techniques looking at so-called perfusion are relatively low resolution. They are not quantitative, and they really give very little information about the microcirculation other than if there is or isn't flow. They give indexes related to perfusion, of course, and this will change from patient to patient. An alternative methodology looks at the oxygen availability, and the near-infrared spectroscopy is the best known of these, and actually looks at the redness, if you like, of tissue as an indicator of the presence of oxygenation. Again, a non-quantitative technique, and this has been used in many studies. A more sophisticated version of this is by looking at fibers, which also looked at reflectance spectrophotometry, and these can be used to look at, in this particular study, at the oxygen availability in patients who've had tissue reconstruction in burns. However, all of these methodologies, however patient-friendly they may be, do not really deal with the main problem, which is how do you quantify what is going on in the tissues in terms of the oxygen transport capacity of the tissues. And there are two which are very important. One is indeed the perfusion or the convection of the red blood cells. This is the frequency with which red blood cells, oxygen-carrying red blood, enter the tissue area. Almost all of these techniques look at that. But there's also, of course, the density of red blood cell in a field of view, which will determine the diffusion distance which oxygen has to go in order to reach the cells. And it's this diffusive capacity, which is the red blood cell, the vessels, the filled functional capillary density of the field of view, which is lacking in all of these particular techniques. This, however, can be directly imaged using bedside handheld vital microscopy, as we can see here is an example of one. It is usually placed underneath the tongue, as you can see here in this angiogram. The tongue is vascularized by the external carotid artery, and we can see in great detail the red blood cells moving through the microcirculation. And these images allow us to look at the density of perfused vessels and also at the velocity of these perfused vessels, allowing both the convection and the diffusion capacity of the microcirculation to be determined. And why is this important to have both on board? Well, it certainly is the case in fluid resuscitation. For example, when we've got hypovolemia, we will indeed have a problem of convection's limitation, in which there is a slow movement of the red blood cells, and when we fluid load them, we will see a faster movement of these red blood cells. However, if we continue to give too much fluids, we will dilute the microcirculation, and less red blood cell availability would be, even though they might be moving at high speeds, and we will get a reduction in the diffusive capacity by reduction in the functional capillary density of these vessels. So that's why the optimal fluid volume would be here, in which there is a good balance of these two components of oxygen transport to tissue. Now, all of this is very, very difficult to analyze in these images. That is until Matthias and our group developed the automatic quantification of these different variables of the microcirculation in an automatic tool called MicroTools, published last year in Communications Biology. And this allowed not only identification of all the vessels, but also using these so-called space-time diagrams to calculate the red blood cell velocity in each one of these capillaries, and actually enabling histograms of the distribution of red blood cell velocities, in short, allowing a complete and comprehensive description quantitatively of these microcirculation images. And just online, these were validated in a large international database looking at various different disease states from different groups, and also looking at which interventions, looking at the either diffusive or the convective component of resuscitation, identifying which of these two are the most effective in altering the microcirculation. So getting back to the basic physiology of this particular thing, it is the oxygen content in blood, which is a dominant factor of oxygen. So we need to look at these microcirculation and the red blood cells in that. And that brings us to capillary hematocrit, which is really the number of red blood cells in a single vessel, which will determine the oxygen carrying capacity of that particular vessel. And the less there are, the less that that will be the case. And of course, it's not only the presence of the hematocrit, but the frequency at which those red blood cells travel along the capillary, which will ultimately determine the oxygen transport capacity of the microcirculation. We actually did this in a very comprehensive study in which we looked at the images of the microcirculation and were actually able to calculate the capillary hematocrit. And we showed that in patients, cardiac surgery patients, that when these patients were given colloids, which is what you would expect, that the colloids actually increase the distance between the red blood cells, which is exactly what you would expect from a volume expanding resuscitation fluid, and that this actually results in a reduction of the capacity of the microcirculation to transport oxygen. Ironically, this reduction in hemoglobin is considered as a negative effect of colloids. However, it is the precise purpose of that. And we were able to develop the microtools in more detail and to actually be able to make an algorithm which allowed the calculation in each individual vessel of the capillary hematocrit. So this made us think more and more about what it is that we exactly want to do when we describe a parameter which improves upon resuscitation. It is not only the convection, but it is also the perfusion. So we introduced the tissue red blood cell perfusion as a component which tells you the number of red blood cells going through a field of view in our resuscitation. And we applied this in this particular pig model during hemodilution. And here we can see before and after the hemodilution, actually showing the reduction in the fluids. And with my final slide, we see here that as you hemodilute and the viscosity goes down, the increase in red blood cell is evident, more perfusion you would expect. But if you look at the red blood cell perfusion, you actually see it going down because of the dilution of the red blood cells. So even though the velocity might go up, the actual parameter, the tissue red blood cell perfusion goes down, showing this to be indeed a very useful parameter for resuscitation. So in conclusion, it is generally accepted that the ultimate goal of resuscitation is to improve tissue perfusion. However, what is precisely meant by that is unclear. The tissue perfusion devices either give non-quantitative index relations to velocity or hemoglobin oxygen saturation, but direct observation of the microcirculation by these microscopic handheld devices allows red blood cell availability to be measured very precisely, and we define the tissue red blood cell perfusion as a parameter which quantitatively allows flow to be measured, and taking both the convection and the diffusion capacity in the tissue availability of red blood cells. And a microtools which we have developed allows a point of care calculation of tissue red blood cell perfusion, which we think will be an important resuscitation parameter for the future. Thank you very much for your attention.